I'm going to try to take you on the journey of COVID pandemic, the way I see it currently here from when it started. So with that, my objectives for this evening for us are to learn together to know the virus a little bit more, epidemiology update, some clinical features, and obviously focusing on MISC and vaccine updates if we do have time for that, but you can shut me off whenever, so I can talk a lot. So we'll go down the memory lane and just do a timeline reminder to everybody that December, although it seems like forever and a day, it's actually been 6 months and not forever and a day. You know, the days seem really long with this, but December is when we first had the virus case as a human-to-human transmission recognized in Wuhan, in China. And 30th January was when WHO declared the outbreak to be a public health emergency of international concern. And then 31st January was when US officials declared novel coronavirus to be a public health emergency. 11th March is when WHO declared that COVID virus disease was a pandemic of a very large proportion, and we are still struggling with that currently. And we see the virus not only in US, but in more than 200 countries across the globe. So this is just to sort of show you the snapshot. And then, you know, I think how did it really start? It's always that mystery that puzzles, you know, all of us ID folks, obviously, but I know everybody, all of us, you know, physicians, and even like my mom, everybody is wanting to know a little bit more about this virus. So I think this was a slide that I had made when I got the chance to show you a little bit of this in my last talk when Sandy was also there. But just to remind everybody that this is a zoonotic virus that, and we are an accidental but a host that the virus has discovered a lot of love for. It's just growing and spreading, but nonetheless not the actual preferred host in nature. So when coronavirus, you know, spread to humans, they actually need like an intermediate host, and this cute little mammal here, pangolin, was thought to have been the intermediate host. Obviously, nothing has been really established, except we do know that this virus indeed is linked to a bat. And then we do know that this is definitely zoonotic, and it's potentially coming from that live animal market, which has thankfully been closed on January 1st, 2020. So no more bat viruses from there. Virology 101, and I'm not alert on this one, but bear with me, because as you get to like look at papers or even just listen to the news, you'll hear more and more about vaccines. So I think it just at least helps all of us, you know, answer some potential questions when families ask us, and look at the paper in a way that is a little bit more scientific, because I had to remind myself also of the structure. So just briefly, this is an enveloped RNA virus. And the schematic shows you, it's an adaptation from Field's biology textbook, but it's a nice depiction because it shows you the structure the spike protein, which is the infamous spike protein. I don't know if you all have heard of it, but the S protein, and that's like the target for all, a lot of the vaccine, you know, and also for a lot of immunoglobulins or monoclonal antibodies, so to speak, that are getting this, to be like discovered, and money is being invested on that rightfully. So we do have the full genome sequencing, and we do know that this is very much connected to the SARS virus and two other bat viruses. It's not exactly the same, but it's very much homogeneous to that virus. So it has that membrane, which is the M protein, and then it has these spike proteins, which are kind of highly glycosylated, and they are sort of coming out of the membrane. And then you have these other proteins, which is the bilipid, obviously envelope layer, which is the E protein, and then you have the nucleocapsid here, and then you have the mRNA or of the virus that is actually within the nucleocapsid. And the membrane is derived with help from our cells, the host cells. And the black and white picture here shows you an actual electron microscopic view of the same schematic that I showed you on the other side. And the arrow points to, again, that those spike proteins, which give it its famous name. It's almost like a crown sitting on its head. So it's certainly ruling over the world right now. Hopefully we can win. So, and then moving on just briefly to the proposed pathogenesis, because then it's the natural next step for any of us, right? How is it actually going, and where is it actually, I think this slide move there. All right, so the way it enters, the first step really is the binding, and this is the ACE2 receptor, which kind of lines our nasal epithelium and the airway tract all the way to the lungs. And the virus, as you can see, the spike protein kind of binds to that and then is taken into the cell. This is the cell entry, and the viral genome is released here. And it takes the help of our cells and just makes a lot of viruses. It just puts our cells to work, the cell apparatus. It makes a multitude of these proteins, which then get assembled and make many, many new viruses like this. And then these viruses eventually come out of the human cells by exocytosis, and they just kind of float around there and cause that inflammatory reaction. So that's like the pathogenesis. I thought it was important to start grasping at some of this also, so that we can understand where the drugs and vaccines are coming from, and maybe have a better understanding when we explain to our patients. This is a little bit more of like disease progression slide. So the first one here, A, actually just is exactly kind of what I told you. And another term here, this is really moving fast. So the other term here is that TMR SS2 receptor, and I think there's other people on this call like Linda and everybody who potentially like kind of know a lot more about this, but this is also like one of those receptors which kind of this virus likes and gets attached to it. It's also lining our airway. And then, so as it enters, that's your first one, and then this B section, or the figure right below that, kind of shows you that the inflammation is, when the progression is kind of also including a little bit of the alveolar capillaries, and this is a section of the alveole. And then when you look at C, then you can see the late stage COVID, where because of the presence of the virus and the replication, there's continued inflammatory response, and then you have the whole kind of cascade happening, which happens a lot more in adults, and that's why they can have this irreversible lung disease / pulmonary fibrosis as healing, and but not as much in children that we have seen here in Memphis, and mostly across the world. We haven't really seen that much of late sequelae in children. But I think the important thing here to note is that it's not just a pulmonary disease, and that's the concept, really wanting to hit home. And we've heard this, but I think showing the figure helps, because it's a pulmohematological endothelial inflammatory consequence, which is more than just pulmonary disease. So a little bit different from, say, RSV or adeno or even flu in the lungs. So with that, this is a nice figure borrowed from colleagues at Emory, who are producing really good figures to this to help their students and learners learn. And I really like this one because it shows you how, to talk through when people ask us, well, the coronaviruses have been here forever, why is this different? Well, it is because these are the differences. We do have common cold coronaviruses, but this is different from SARS-CoV-2. Also, SARS-CoV-2 is different from MERS and SARS-V also, because it's more transmissible. And it's also, you do have more asymptomatic transmission, in which way it's more common to the common cold coronavirus, which spreads easily, but it's more similar to MERS and the SARS-CoV from before, because it actually causes ARDS similar to them. So it kind of is, best of both badness in a way, or taking the bad points of both parents, so to speak, and behaving like a perfect bad child. I do have a teen. I hope he's not listening and thinking I'm making illusions. All right, so let's talk about numbers, epidemiology, and let's see where we are, right? The reported case counts, and this has been so debated, and I know everybody is on different fences on how the reporting is done and where should it go to. Without going into any political aspects of that, I think the burden is still pretty significant, whichever way we look at it in our country and in the world. So I'm just going to take you through some of that. So in pandemics, I always tell our residents also, it's good to have a global perspective, because we could get so lost in just our own little like fighting, should we wear the mask, should we not wear the mask? And so, so many other things. There I went political, wear the mask, okay, tell people to wear it. So I think it's important to see what's actually happening in the globe. And if you click right here, it takes you to this great interactive podium, which is from Johns Hopkins, and you can just pretty much see where we are and where the world is. And again, the data is as good as it's reported, right? So there may be countries which are underreporting. So all that taken with a grain of salt, but still pretty significant, here. And really, if I click here, like say, I'm kind of wondering about what's happening in India, and I clicked in South India, Pondicherry. I've been there, spelled wrong also, by the way, which has had 2,092 confirmed cases, and it may be more, but I can pretty much like go anywhere. And then if I click here, I'm in Illinois, US. So it can just give you that perspective and gives you like where we are, where the world is, and you can see here that we are, we have not had a lot of victory in terms of cases with this virus. So as of today, there have been 611,000 plus deaths globally, which is a lot, obviously, and then many, many more cases, and US has 141,000 plus deaths as of this afternoon. So this is again, a perspective slide of our country, and this is taken from the UT website, and this is like, you can access it live also, and you can definitely look at it, but I won't in the interest of time. I'm just going to kind of tell you that this is the data from today. This is actually from CDC, I'm sorry. This is the country perspective. And you can see here, the reason I wanted to point this out is to kind of like just point out as pediatricians that we are only seeing very little. Our adult colleagues are seeing way more. I think we all know this, but just a take-home point from this is that of all the reported cases in CDC so far, only about 6% or 6.5% of them have been in children. And of those, in the 0 to 4 age group, it's only 1.5%, even though they are the sicker kids, but there's not that many. And then majority of cases which have been in the 5 to 17, but it's still a very, very minute portion of the whole, if you look at the whole countrywide also. And then similarly for deaths, for us, it's kind of good news because the deaths have been less than 0.1% in children. So just focusing on that part, really, it's not been, kids have, largely not bear the brunt of this when it comes to the actual disease itself. This was the other one I kind of got confused when I was talking about. This is Shelby County and Tennessee data, and this is also, you could go live, but I took a picture of this to show you, and this is also from today. And then here, the cases that we have as of, this was last updated on July 19th, and this is work done by, led by John and Dean and everybody, but this basically shows you the cases here. So we at Shelby County have had 16,000 plus, and then the Tennessee total has been here, and these are the number of deaths and everything. So this is also, I think the point on this one, and if you go and look at this website detail later, this is open to public, and I think any of you can access it. It'll show you that they have like split by age, and you can see that the cases are rising in young adults here because they're not masking, and some of it is inevitable because they're going to work, so they do have more exposure than they've had before, which may have not been prevented, but some of it is driven by not using masks. So this is the LeBonheur snapshot of our cases, and this is as of July 17th, that we had tested 5,234 kids from LeBonheur, and including those that were in the ED, and we had a total of 148 positive. 38 of those kids were, 38 kids were admitted overall at LeBonheur with a positive COVID test done at LeBonheur. 2 were admitted twice, and 17 of these are asymptomatic. And some of you in the community may or may not be aware, but we have implemented universal screening at LeBonheur. So anybody who comes to LeBonheur in terms of patient gets screened, whether they're symptomatic or asymptomatic. Their isolation depends on whether they are a PUI, a person under investigation or not, but the screening happens for everybody. So that happened around May 16. So data, we do have more positives since then, but not that many more. So even though we tested so many, we expected a little bit more positive, but we don't have that many more positives. The MISC KD reported that we've had, and we've been reporting it to the state since last month, and we had 9 that are reported to the state and 3 that are being reviewed by the state. So we've seen our share of MISC cases also, or MISC, whatever you want to call it. So taking you through a little bit of the details of the epidemiology after giving you that, the top-down view. This is the first data that we had for children, and this was just MMWR weekly report, which did not have a lot of information. It was like a retrospective review, and they, because the disease was just sort of coming out, they did not have like the best databases then, and people did not give all the information and stuff. So it's incomplete, but what it did tell us was that of all the cases that were reported to CDC during that time, all the way through April, which were coming mostly from the West Coast, as you know, about 1.7% of the lab confirmed cases occurred in children less than 18. The median age was 11 years, and most of the cases, or 57%, were in male, and about 2/3 or 1/4 of them close to had an underlying condition, which we know that underlying condition has been a big deal with the adults also, but in children also, that's kind of the first data that we had there. Less than, the other thing here that we kind of got to know is that children less than 1 year accounted for the highest percentage. And this was a little bit different from the data from China that we had obtained earlier. So I kind of still like to show a little bit of that. The signs and symptoms of this illness in US were reported as fever in this first review, and cough or shortness of breath, myalgia, runny nose. So just all the usual like flu-like symptoms, along with abdominal pain and diarrhea. And then a very small minority of them developed worsening of illness during the second week of symptoms, which is thought to be more characteristic of adult COVID. Not that it can never happen with children, but not something that panned out to be really a big deal for us. And then the X-ray just depicts to you that those multiple areas of consolidation and bilateral infiltrates, the ground glass opacity, and sort of the halo sign characteristically in ID world associated, kind of thought to be with aspergillosis or fungal diseases, but obviously now we know that COVID definitely can cause that. The big thing to remember here is that the X-ray can also be normal and is not always indicated. I think the second study about epidemiology that I wanted to really share is one that came out from Pediatrics recently. And this is, I like this because this is looking at, even though it's looking at one US children's hospital system in New York, they did do a really good job of collecting all data. So in terms of really the grit of the study, it's pretty good. I think this is from a New York Children's Hospital, and they had 65 children during their peak time that they saw. Some of the take homes that I summarized for you were that I think the most important one, and what I mentioned in my resident talk yesterday also, that fever was common and seen in about 74% of cases. And even you should also, the history of fever is as important as just having fever in the office. And not that you can do that much about it, but if you have a suspicion of COVID then. Also, and for those of you who also admit, I think the other important thing that they kind of saw was that during the peak time, most of their kids or infants who were less than 2 months of age that were getting admitted to the hospital were admitted because of COVID. I thought that was pretty telling. So meaning that these are, I think, some of the things that led to universal screening for us also, that it is really very common. If it is in the community, then the kids who are coming in, the infants, they're most likely, if they have fever, they might have COVID, especially if they're less than 60 days of age. And that's kind of what they saw. So the diagnostic and treatment consideration, sort of briefings or my take-home points on that for whatever, my wisdom is worth on this. And these are things that are actively evolving. So when we talk after a couple of months, I may have, a little bit different information on that. But as of what we know right now, the best, and this is something that won't change, the best diagnostic test is going to be PCR. I don't think this will change at all. The best, because we can't grow this virus well, so I don't expect, and culture will take a long time, and PCR will be the test to, that will be like the gold standard. Antigen, which is, I know, something that a lot of private practice offices are going to look at with the flu season coming up, to see if they can do some kind of triaging to help with the isolation and anticipatory guidance purposes. It's helpful, but I think my take is that a positive test is helpful and a negative is not going to be helpful. And there may be false positives also. So I think more to come on that. You know, I mean, I guess it's better than nothing. I would say it's 60 to 70%, depending on where you look at it. But it's not, we know from our flu and experience also, and from RSV experience also, that it takes a long time to perfect an antigen test. And it's, we'll see, is my quote on that. Serology for antibody, I think this is important. This is something that we need to keep looking at data, because this is going to give us a lot of information now. For office purposes, I really don't think this is something that you need to really worry about unless parents are insisting on wanting to know. Like if they've had, like somebody had, you know, if there's a family member who has COVID, who's an adult, and child is overall doing okay, and the family really wants an antibody test in, you know, a couple of weeks to see if their kid is, you know, has this protection level or, you know, whatever, that immune correlate of protection from that, which we don't know what's the right number yet. But in case they ask you, then it might be something to consider. I know that people are already asking in the community whether they should get that, and then that gives them more confidence in sending their kids back to school or whatever that case might be. But don't ask me questions about back to school. Those will be I'm just going to push them to Dr. Yan if you do, because he can answer the school questions, Jason. All right, so the other thing about serology, I think it has a big role. It does have a role in MISC, not in terms of like diagnosing MISC, because you will diagnose it based on clinical, or we will diagnose it based on clinical symptoms, and we would assume COVID in the current scenario if we can't find anything else. But I think that will help us understand MISC a little bit better, and having a confidence serology in that setting is going to help us have a diagnostic closure of sorts on that case. Eventually, I hope that antibodies are going to provide us on who is going to be susceptible and who's not going to be susceptible. It's going to be a good way to study which vaccines are going to be effective, and people are already sort of doing that. So there will be much more to come on antibody. I feel like that's a test to watch for. For other diagnostic and treatment consideration, I think one thing that is sort of nice to know from a private practice perspective is that if you're suspecting COVID, then you know, even if you're sending the patient home, then, which you should if they're fine, then acetaminophen should be your preferred, you know, antipyretic, and not NSAIDs. Although if we do have to give NSAIDs, then a lower dose is preferred, and this is because there were some toxicity profiles reported early on. They haven't really panned out as much, but that is sort of the WHO statement, and that it can potentiate a little bit more of renal side effects of COVID. So use acetaminophen whenever you can, but NSAIDs are not like absolutely never give it, but a lower dose if you really have to. ACE inhibitors you don't really use, but if you do have a child with metabolic syndrome who is on it for blood pressure issues, then you can continue to use it unless there's other reasons to discontinue. Obviously, immunosuppression, if a child does have COVID, then it's, or any virus, then it's, if the immunosuppression can be reduced, then it's always good to do that as tolerated, obviously in conjunction with other people who are helping manage those medications. So other like pharmacotherapies wise, I think this slide just takes you towards, and that's why like I wanted to spend some time on pathophysiology, because then you can really see where people are targeting the drugs and where are the therapies being given. So I'll just say a couple of things here, that the arrow that is pointing to remdesivir with RNA synthesis, that's the drug that's really has promise, and that's the one that we are using. We have access to that. We've given it at LeBonheur. Hydroxychloroquine, we can forget about it. in this setting. And then dexamethasone, that is something that also has promise. And I know Dr. Shah is listening in to this talk. So especially in the ICU setting, in the kids who are with ARDS, in adults at least, that they've shown that that has benefit. So I think that is something that we will continue to watch. The arm for the children in that study is not out yet, but that is something that has shown promise. The others are the anti-IL-6 receptor, like all the inflammatory response that is created with this virus. So those are also like have some promise, and the convalescent plasma, which protects the binding, as you can see, it just blocks the virus, so it can't really go and attach to the respiratory epithelium. You can give, we give that, or we have given it at LeBonheur a couple of times for acute infections. So treatment data that we have so far is from adults. My bottom line on that is kind of what I told you, is that dexamethasone reduced the mortality in patients with COVID that needed ventilatory support or oxygen support of some kind, not in those on room air. And then preliminary results from trial in remdesivir, this was from New England Journal, they showed that it was superior to placebo in adults. And we've used it in children. The data for children is mostly right now just anecdotal cases, but not really a case control study. So, all right, this is just like a break slide for us to see if anyone has questions so far, but also to reiterate that COVID is really not flu, not that you all don't know that, but I think this speaks a lot that if you just compare mortality-wise, over almost the same period of time now, 6 months, it's kind of astonishing. All right. So again, this is just also a nerd alert slide to just tell you that COVID is not flu if a patient has that. And this also shows you the extrapulmonary tropism is much more than what you would expect for usual respiratory virus. We don't expect flu to go and be found in the kidney, which we can find COVID in the kidney. We found COVID virus in amniotic fluid. So it's kind of really out there, and it goes to organs beyond the lungs. So why is it different in children? I know that I wasn't asked to speak on that, but this is a question that has puzzled me a long time, and that I have had to explain to my mom and to my son and everybody. So I think this is really intriguing, and I just want to take a couple of minutes here to talk to you all about this. I think if this is a slide that really speaks a lot to me, because it tells me that even though I'm worried about the children in the community, when I look at this, I can see easily that even considering Missy, we still have, it's still very rare. The presentations in children, the children do overall much better than even the mildest inpatient adults. So why is that? So a lot of thought has gone into that. I think I'll just say that the ACE2 receptor that I talked to about is the one that has got the most fame in this. So children are really, if you look at my jumping ahead to this one, then it's like the ACE2 receptor expression is needed for this virus to go in. It has to be sort of active, and it has to be engaged with the things that are floating by in our respiratory epithelium lining. But for children, they actually have less ACE2 expression, which has protected them. So they really, their ACE2 gene expression is not super active, and it gets active over age. So that's why as they get older, that's why the 18-year-olds are getting a little bit sicker with the exposure, but the younger ones maybe are not from respiratory standpoint, although they can have extrapulmonary manifestation when they are really young. So that has been like one of the most touted explanation. The other one really goes to the fact that adults have an immune system that is a little bit different from children, where their inflammatory response is a little bit maladaptive. And I think Dr. Shah, you can jump in and speak to this at any point if you want to, but basically the fact being that they can have a little pro-inflammatory milieu in terms of like being, releasing cytokines that are more destructive than children who can have cytokines that are not that destructive, and there are actually immunomodulatory cytokines that can be released in children, so it might be more protective, and that has been done to be the other reason. So with that, I'm going to start talking about the MISI update. I just want to take a break here and see if anybody has a question. Have people fallen asleep? Are they still with me? I see some people awake. Any questions so far, if you all can talk?
Hi, Dr. Bagga. This is Nitya Swaminathan. Thank you so much for the excellent talk so far. I had a question regarding the transmission. They say children are super spreaders. I just wanted to ask you the question, is that real? And your take on that.
So, my take on that, I'm going to be Dr. Fauci, even though I'm nowhere, not even a small f on his word, and say that we don't know. But from what my review of the literature, I would say no. I don't expect the children to be super spreaders. As you can see here, they are not actually super infected also. When the incidence is so low in them, I don't expect them to spread it as much. And although people take that with a grain of salt, because once the schools open, then they may have more chances of infecting themselves. So that it might change a little bit, but the studies that I could not show actually are some from European countries where they actually have opened the schools, and there are some also just from Chicago where they looked at household contacts and spread with children, and most of the kids they could find were actually getting infected from the adults and not vice versa. So I think in simple words, I don't expect them to be super spreaders. Can this change when the literature is out and proves us wrong? It's possible. But what I know right now, I would say no. Does that answer it?
Yes, thank you.
All right. Any other questions?
Oh, you need a job, sure.
All right. Was that a question? Okay, so MISI update. So what is MISI? It's a multi-system inflammatory syndrome in children. So this actually is really interesting, and this slide is from the Public Health England. So this is truly, very in pandemic, we rely on collaborations and learning from colleagues, and this is actually a slide that or data that they shared when they started seeing that after they had their peak, they started seeing that they had these kids coming in with Kawasaki-like syndrome, but not quite Kawasaki, and they were really puzzled, and they couldn't really find any other viruses, and some of them had these, all they had was that COVID, but they did not actually have a lot of respiratory symptoms necessarily, so they were really puzzled about what's going on, and they described this multi-inflammatory syndrome and thought that it was temporarily associated with SARS-CoV, and it had a name change from PIMS to MISC, but the current name is MISC or MISI. So it follows a 1 month lag or 2 weeks lag. And this is kind of what they came up with originally, which you can see we've held on to that. And I just wanted to put it out there because I want to reiterate that we are learning from colleagues across the country. So it's important to continue to be collaborative here. So I think the important thing here is that while most children who do come in with, when they come in with this multi-inflammatory syndromes, they may or may not remember or recall, their parents may not recall the SARS-CoV infection that they've had. We may have to just assume that. So right after that, New York started seeing cases, and we had multiple webinars on and a lot of ID like lit search email that went around, which described the New York cases, which are very similar to the UK and Europe experience. And then CDC came up with this definition, again, nicely put in this picture, that this should be diagnosed and considered in a patient less than 21 years old with all of the following features. And it's a kind of a loser criteria, but I think it's designed to not miss a lot of cases. But fever for more than or equal to 1 day is what they said. and then hospitalized with involvement of more than or equal to 2 of the following organs: renal, neurologic, respiratory, GI, dermatological, cardiology, and heme. So any symptom with any of these, or any sign with any of these organs involved, 2 or more, and then evidence of inflammation, and that had like the elevated CRP, ESR, IL-6, neutrophils, meaning that you would expect them to be lymphopenic and have neutrophilia. The coag channel abnormalities and low albumin, and not written here, but also added later on, was low sodium. So only 1 of these lab values are needed. So you don't need to be all, positive, but you would be typically if you have it, but even with 1, you should suspect it. With that, like, you do need to have no alternative possible diagnosis. So you should be looking at other ID versus like rheumatological etiologies in parallel. And then obviously the SARS-CoV-2 positivity, which is an RT-PCR, a serology or antigen test, all are acceptable for SARS-CoV positivity, but really COVID-19 exposure. So they don't actually need to have the positive test to be considered, or you could send it and it can be negative, and just the exposure counts, which is essentially like, I think, we don't know, it's potentially most kids in our community right now, anybody could be exposed. We just don't know because there's so many asymptomatic adults also. So the differential diagnosis for this is obviously Kawasaki disease or Kawasaki shock syndrome, rickettsial infections, toxic shock syndrome, with group A strep or Staph aureus, and that's important when we are treating these kids and evaluating them in the ICU. When you guys see them in clinic, obviously this is important. Other bacterial infections or sepsis with other organisms mentioned there, and then just viral sepsis. It could be in enterovirus season. I was talking to a colleague in Tampa last 2 weeks ago, and they are starting to also see enterovirus now, and they can also come in with sepsis-like syndrome, viral. This is a season for other viruses also now. And then myocarditis could also be due to other viruses. And then lastly, the HLH or macrophage activating syndrome, which could be part of COVID or it could just be isolated. And I see Dr. Myers also on the call, so she knows that a lot of things cause this, and a lot of other rheumatological diagnoses for which we don't have to go into. So for COVID and MSc in US, this is I think the best case study paper that's out for those of you who are interested to look at it later. It's a case series that came out of Northeast, described 6 cases. But we won't go into that because we have our own cases here, which are almost similar in number that I'll take you through a couple of those. But this is like, if you, kind of get bored when we go over some case details, I just have it summarized for you. So you can see the age range is one thing I want you to note, right? When we're talking about Kawasaki overlap, look at the age. This is not what we would expect the age to be. If I'd shown you, if I'd seen Kawasaki, then I expect much younger kids. So the kids that we've seen, apart from one who's a 6-month-old and another that was 3-year-old, most of them have been, and an 18-month-old. A lot of these kids have been older, and a lot of them have had negative PCR. And then serology was not available when we first started seeing some of these kids, so they were not uniformly done, but we've had a couple that were positive. 2 of the kids at LeBonheur have not necessarily related to MSc, but have received convalescent plasma, and 2 of our kids have received remdesivir. Again, those are not necessarily MSc kids, but I wanted to, in the same slide, show you that we are giving this, and we do have the capability to do these things as if needed, because I know that parents are asking you guys. So the first patient that I'll take you through is one that I saw actually when, I'm gonna move this a little bit, sorry. The first patient was an 11-year-old female with past medical history of arthralgias who had an asthma, who presented with fever, abdominal pain, conjunctival injection, and hypotension. She had this 4-day history of fever and right lower quadrant pain, 1-day history of vomiting and diarrhea. So nothing really out of ordinary, could have been just like a GI bug, but did have this history of a conjunctival injection on recall. So during the time when she had this GI-like illness and the pink eye, she called PCP, and some azithromycin was prescribed. Due to some new symptoms of headache and neck pain and fever, the PCP then said, go to the ED. That was kind of 4 days in. In the ED, she was hypotensive with the blood pressure of 69/38, and abdominal exam was suggestive of an acute abdomen. CT showed this, she showed some fluid collection also, that we might expect that in just a septic-like picture. This kid kind of almost needed intubation, but mom was not really wanting that. So it was really on very high non-invasive support when I saw her, and she was given some antibiotics and started on just management for sepsis, and COVID testing was also done and was negative. So these are the labs that when she first came in, and you can see the high CRP and some transaminitis. So she does meet some of those criteria that I just showed you, right? So I think most people who just saw the criteria would say that she's kind of meeting some of them. And at that time, we didn't really have a lot of those coming out. So we were just sort of learning about this, and we didn't really have a lot of knowledge that we have right now. So in the PICU then, she also developed a rash. We changed some antibiotics around. I went and saw her. We did another COVID testing, and we thought maybe she has a lot of respiratory symptoms, so she may just actually have acute COVID and is actually negative, but her inflammatory markers and her conjunctivitis did not make sense, and the rash kind of was overlapping with Kawasaki. So, just got in touch and just reviewed the literature that was not that yet available, but looked at the ideal itself and talked to colleagues and in cardiology also and in PICU. And we all felt like she meets criteria for MESI, even though the criteria had not really been sent out by CDC then, but just even looking at European guidelines, we felt like she met that. But you can see that room was consulted, surgery was consulted for acute abdomen. Nothing really panned out there. Her echo also was positive for some mild pericardial effusion, suggesting inflammatory process, but she also had valvular dysfunction. We did not really see a coronary artery aneurysm, but echo was definitely abnormal. And she did have like some lung findings, which were atelectasis and pleural effusion, but really thought to be mostly due to overload of fluid and not really lung disease in particular. So eventually, like day 5, we ended up giving her IVIG, and her fever subsided. She was weaned off presses and her respiratory status improved. I offered mom COVID testing, serology, and she refused. And at that point, it wasn't that widely known. So really, I think Dr. Cross had her later on, and we talked a lot about her, but ended up, we didn't do serology. Not that it would have changed anything, but it would have, if it was positive, it kind of would have nailed it because it was our first potential MESI case. The second kid was this 12-year-old who had no significant past medical history, who had this fever, cough, and malaise, and was kind of just hanging out and not really doing that bad, but not really feeling that good, decreased appetite, vomiting, and then had some dizziness. The interesting thing about this one was this kid was actually diagnosed with COVID at the end of April, 4 weeks prior, and was quarantined at home for 2 weeks by the health department. So when fever returned, they were seen at the minor med and just diagnosed with acute viral illness. When it persisted and she developed a rash, she was brought to the ED by mom. And then the fever and decreased appetite. This is the review of system here for you. As you can see, she met some of this criteria when it came to symptom. She was also, COVID testing was done again and she was negative. Also met the lab criteria. You can see it there, the high D-dimer, fibrinogen, high CRP, low sodium, and the lymphopenia. The hospital course for this one, again, started on antibiotics, and then 2 days after admission, because of worsening, ended up going also to the PICU. the ID service evaluated for everything else. For this one, the echo and EKG were normal, but did have a high BNP, did have a higher end troponin, which trended eventually. And then this patient ended up also getting IVIG and really improved to that. But then because the temperatures came back again, methylpred was also given. And she improved. COVID serology was not positive in the hospital, but a follow-up was done in this child and was positive at follow-up. So I'll take you through some of the literature that we have for this particular condition. And I think to understand whether this is, and we have cardiology friends also on the call. So just a little bit on how different is this from Kawasaki disease and Kawasaki shock and toxic shock, just looking at the data for that for you guys. So this Lancet article actually compared this Kawasaki disease-like illness, and this is from Italy, when they started seeing a burst of cases that came in with this Messi/Kawasaki disease-like illness. They went back and looked at the patient and the clinical demographics and the clinical characteristics of these patients versus the retrospective Kawasaki disease cases that they had in their hospitals over the years. And they kind of came up with the comparison. And this is what they found in a nutshell. Like, if you don't want to look at all those boxes, you can look at the blue on the top and just kind of take the bottom line. That kids with this Kawasaki disease-like syndrome were different from the typical Kawasaki in the sense that they were older. They had higher ferritin. They had more abnormal echo beyond the coronary artery aneurysm. They had lower platelets, which we do sometimes see with Kawasaki and Kawasaki shock, and especially in younger kids, but we don't typically see that in Kawasaki. We actually see more of thrombocytosis. They also had lower WBCs, which is very also uncharacteristic of Kawasaki, where we see higher WBCs. So how does this happen? This is again a great question, and I'm sure like somebody somewhere is looking at this and trying to will tell us in a couple of maybe a year or two, a great paper will come out on it. And really, right now there's a lot of speculations. We know that this is a temporal association. We know that a lot of viral triggers can release this cascade of inflammatory response, which can have a time lag. And given the right genetic predisposition, that all kids who get COVID or all will not develop MIS-C, but a portion of them who are susceptible might get it, where the immune system kind of get rogues over them. We also know that for Kawasaki disease, not all kids who get viral triggers end up getting Kawasaki disease. So there is definitely a genetic predisposition to these disease characteristics. And so this is the same pattern, except this is behaving a little bit differently from Kawasaki. So this then looks or shows you the data, and I think it's important to show that to my physician friends, because so that you don't just take what I say at face value, but you're actually looking at the graphs yourself, and then you have it summarized there. When you look at this, they called it PIMS, but it's the same thing. It's the MIS-C. And the Kawasaki disease shock, and the traditional toxic shock groups that they compared in their hospital. What they found was that the MIS-C kids obviously were older, and the average age of Kawasaki was 2.7 years, which I think is what we would agree also. When you look at this, which looks at the lab value differences, again, I think you can see here that the lymphopenia, anemia, and thrombocytopenia, in some ways, in all of those, the MIS-C is more comparable actually to either Kawasaki disease shock or toxic shock. And not really, that's why it's confusing. And those are not characteristic of Kawasaki disease, but they're more characteristic of toxic shock. And that's why the initial confusion on whether it was bacterial or not. And that's why some of these kids end up getting bacterial therapy, and they should also be evaluated for bacterial pathogens. All right, and this looks at inflammatory markers. So here you have the CRP, ferritin, D dimer, and how you can see how it is also different when you compare these, and you can see how the labs are a little bit out of proportion, especially the ferritin, like I told you before, and D-dimer is one also, which is characteristically different for this also. This looks at the troponin and the BNP elevation and how it is way out of proportion when you compare it to Kawasaki disease and Kawasaki disease shock. And I think that can be in the presence or absence of echo findings. And I showed that to you in one of our cases. That's why I picked that case for my cardiology friends here, that even though the echo is normal, like for me as a hospitalist, I may not always think of ordering it. We go by echo, we don't necessarily get BNP and troponin for all kids that come in with Kawasaki. So it was an important thing for me to sort of consider and change sort of my behavior and learning process and treating process for this. So I think the bottom line for this in terms of literature review thus far is that admit labs and other parameters like age are discordant between the new COVID-19 induced syndrome and both regular Kawasaki disease and Kawasaki disease shock cases, and can be more similar to toxic shock. And again, the higher age of presentation, predominance of GI symptoms, low platelets, increased D-dimers, and hypotensive shock. But they are similar to Kawasaki disease shock or to toxic shock, but they may have the rash, the conjunctivitis, and the cardiac findings and other overlapping features of Kawasaki disease. So what do we do with this? So this picture is, this slide is, from a friend that I've modified. She's in Wake Forest right now, Casey Ramirez. I think a lot of you know her. So this is something that they have come up with, and I think it's very similar to what we are doing in our hospitals. I've modified this a little bit to our hospital guidelines, but basically these are the labs that we would be sending for any kid with these symptoms and fever, while we are evaluating for etiologies that are including COVID, but not just COVID. So you have blood culture written there, you have UA and urine culture written there. So we are, and in tick-borne season that we are, which is now, or any season potentially, except like if it's really cold. But we don't evaluate for tick-borne, so I didn't put that here, but we might empirically start them on doxy because it's hard to rule that out for us. Supportive care and IVIG was sort of what we considered as the mainstay sort of for us as first line. But there are more guidelines now from the Rheumatological Society and AAP, which I'll share in just a minute. But these are the antibiotics that we would start them on empirically. If they come to ED and if they're in the PICU and I get a consult, then that's kind of what I would say. Vancomycin, ceftriaxone, meropenem if there's abdominal pathology, and doxycycline. So what do you do in the outpatient, right, is what you want to know. So it's tricky because if you have this potential ticking time bomb that they could get really worse, but they look okay. So what do you actually do? So I think this is something that you might consider, like if they have fever and they have for more than or equal to 3 days, plus at least some of these symptoms, then, but they actually look, say they have fever and they have headache and red eyes and cervical lymphadenopathy, but they're actually looking well and you're not really sure, then it's good to do some initial lab workup, I think, if you have a quick turnaround, and those labs might include CBC, CMP, ESR, and CRP. And if they are abnormal, meaning if any of those are abnormal, so it's not that they all have to be abnormal. So the only way to send those kids home or not like do more about it would be if the CRP was normal, ESR was normal, if the absolute lymphocyte count was more than 1,000, which is normal, and platelets were more than 150. In that situation, then you could have them on close follow-up if you are confident, and that would be see them within 24 to 48 hours. You could also, if any of those labs are abnormal, then they can be evaluated in the ED, or you could also call us to discuss the case if it's confusing. So the vast majority of children, this is the AAP guidelines came out, or like, it's not guidelines, it's just statements actually, which, I just wanted to summarize some of these for you. as you have talking points with families. So I think the big takeaway from this was that vast majority of children with COVID-19 will have mild symptoms and have excellent outcomes, and that still holds true. Only 2 to 5% of the COVID cases in our country are reported to be in children, and really 0.1% death, just to go take you back to the first slide. And really in other parts of the world also, it's all less than 5% of cases have been in children. And mortality has really been quite low. Yes, there is MIS-C, but it is rare also. But not that we don't have to consider that, but it is rare. So this is the time in our hospital that we would be seeing MIS-C, and with cases still ongoing, with us still being in the midst of a, kind of a pandemic and surge, so to speak, even in our community, with the sort of rising / plateaued cases, as you look, depending on one day versus the other, certainly not declining. We still may have kids coming in that could have been infected last month and are asymptomatic. So this is the time when we would definitely be seeing these kids. You would be seeing them in the hospital, in your clinics, and we would be seeing them in the hospital. This is a guideline that came out from Rheumatological Rheum Society, and this is which had input from ID, from critical care, from hospitalist group, and from hematology group. So robust, but really needs more like dosing and other things. So they're working on improving it. But basically, they compared and contrasted the features of MIS-C and Kawasaki for us again. And I think we went over most of them, but I wanted to point out here that traditionally we don't have this, African or Afro-Caribbean or Hispanic descent predisposition for traditional Kawasaki, but here there's more increased incidence in those communities. So that is something to be mindful of, as we take care of these kids. And then patients with MIS-C have more prominent GI, and they also felt neurological symptoms. So I bring that because that's a little bit different from the data that I showed you from European literature, that they kind of want us to also consider when they have neurological symptoms very strongly MIS-C. And then present more frequently in shock than you would with Kawasaki, more likely to display cardiac function dysfunction, which is also something that I didn't really, that would have not registered for me if I didn't read these guidelines carefully, that they can have arrhythmias and ventricular dysfunction which may not be obvious. And that's not something we see with Kawasaki. That's certainly not the arrhythmias. The ventricular dysfunction, yes. All right. And I think the other thing is that even without the features of Kawasaki disease, so if they don't have the pink eye, the red neck, and they don't meet the Kawasaki disease criteria, they can still have an abnormal echo with coronary artery aneurysm. And I think that was also interesting. They don't have to have features of Kawasaki to have that inflammation that is in their arteries. The approach is multidisciplinary, like I said, and the IVIG and steroids are the ones, and then biologics. This is from the AAP statements. They say like you should have a stepwise approach, and that's kind of what the Rheum statement also say. And whenever we start these, we try to give them a taper after that. But at that point, everybody should be involved. Heme consultation is another thing that they want us to do because they can have high D-dimer, like I told you earlier. The cardiac management of MIS-C, this was really interesting to me. The cardiac management is a little bit different than I would expect for Kawasaki. They also, other than the BNP and troponin trends that I mentioned earlier, they also want us to do EKGs, serially while the patient is at least in the hospital. And they don't really have any recommendations for outpatient, but that might come out that they may ask us to and if it does, then we can certainly disseminate that. But as of now, like for every patients with MIS-C, that they want us to do EKGs because of those arrhythmias that might be go unnoticed. And then they have this echo plan, which is very similar to Kawasaki disease echoes. But cardiac MRI is another thing that they want us to do if there's significant LV dysfunction in the acute illness. And then cardiac CT, if you can't see the distal coronary artery well, is the other thing that they mentioned. This is again just from the room guidelines, which is very similar to the AAP guidelines, so we don't really have to go over that. The other different thing from Kawasaki recommendations for this is that there really is a stronger heme involvement. We don't really see that with when we manage Kawasaki disease cases, and really not in toxic shock syndrome cases also. They may have that DIC-like picture, but they don't always need treatment for that. And I'm not speaking as an expert on that particular field, but just speaking from consults on that. But here they are really a little bit strongly mentioning that. They also do not talk about not giving the high dose aspirin, like they don't mention high dose aspirin, which you would give with Kawasaki. They would give only the low dose aspirin, and they would only give it if you have a platelet count that would tolerate that. So they want you to avoid aspirin if platelets are less than or equal to 80,000. And then the other thing they mentioned, which was interesting, but if the coronary artery is above a certain range, then they want us to give aspirin plus also anticoagulate, which is also different from Kawasaki guidelines. So this is a break slide, and to see if you have any questions on MIS-C, but SARS-CoV-2 likes surfaces. Important fact, it can stay in plastic or stainless steel for 2 to 3 days. Any questions on MIS-C, friends? You all there? No questions?
You explained
Dr.
it.
Myers, surely you have something to say?
Actually, I was going to say something.
Yes.
You went over the reasons why they think children don't have as much trouble with COVID in general as adults. And I was going to mention, and you may have heard, I've heard a discussion about the involvement of the thymus too, that children have a thymus and adults don't. And there's one school of thought that there's a T cell dysregulation in this, and that if you have a thymus, you can put out more T cells and do better. So I just thought I'd mention that. I don't know that that's proven, and it's sort of theory, but it's just sort of an interesting thought for why children seem to do better.
I've read it. It just didn't pan out into a paper, so I didn't bring it up. But I think that's interesting.
Yeah.
Dr. Bagga, I had a question.
Yes.
And this was regarding how children, are the children who have MIS-C, are they actively able to transmit the virus? Because typically they are the ones, they're having an immune reaction after several weeks. So are they similar to active COVID infection, or how do they transmit the virus, or do they even transmit the virus during that phase?
I would not expect them to transmit the virus. A lot of them could be COVID negative, and it's more immune mediated. So they would have had COVID infection in the past. So even if their virus is detectable, people say that it's more just inactive pickup of the virus because the PCR is super sensitive. They're not thought to have acute COVID, ongoing COVID infections. There's a lag time of 2 to 4 weeks, people think, between getting it. So I do not expect them to be transmitting the virus.
Great, thank you.
Thanks.
Bindiya, this is Samir.
Hi,
I just had a quick comment, maybe, and a question. There is no absolute test to differentiate MIS-C from some of the other potential differential diagnoses, I guess, just like there is no absolute test for Kawasaki disease as well. In your opinion, and from literature, what is the response to IVIG and the supportive therapy in MIS-C? Would lack of therapy almost rule out MIS-C in some of these other differential diagnoses patients?
I think that's a great question, Samir. I think in our, I guess anecdotally, just looking at LeBonheur sort of response, I think here we we've had really good success with IVIG for the most part. One of our kids needed IVIG plus anakinra, I think, and one needed IVIG and steroids, the one that I showed you. But overall, I would say that most kids, even in the literature, have responded to IVIG. That has been the first line. They've often not required second line of therapy. I do agree with you that once we've gone down that step down approach, then we should be, and we haven't found a bacterial pathogen, which we should have been looking at in parallel, then obviously other conditions need to also be explored. So I guess the short answer is I expect them to have good resolution to the proposed therapies.
Thanks.
All right. So I think I'll just move on. How am I on time, Emily? People bored? Maybe. You want to talk a little bit about vaccines really quickly? Okay, Bill. You can leave. Anyway, if anyone leaves, it's not going to hurt my feelings, but I can share some vaccine slides. We're all friends here, it's okay. So I think the vaccines, it's important to just be a little bit updated on vaccines, and you all may have read some of these studies already, but there's a couple of papers that I wanted to refer you to and just get you up to speed, because there's been exciting information that's come out. So as I started with all that, not the gloomy slides, but at least with showing you that whole worldview of how much COVID we are having, I wanted to end with some hope on the horizon that there are more than 120 vaccines that are being developed globally, according to WHO, according to Dr. Fauci, and I am a self-proclaimed Fauci fan, not going to hide that. So number of months before the COVID vaccine could be ready is 6. So he doesn't say should, he says could. And I think that's the important factor to remember, that no one really knows, but it's possible. And that'll be the first time in the history of ID and vaccinology that a vaccine might be ready within 6 months of the genome being sequenced. So that would be a miracle if it's ready in 6 months. 319 million is the other number to remember. That is the minimum cost of getting a single vaccine to the large scale testing stage, according to the estimate published by Lancet. This schematic is just to show you different vaccine types. And again, this is not going to be a vaccine lecture, but I think it's important to just sort of see that, get reminded that live attenuated, then whole inactivated, the RNA and DNA recombinant subunits, and the recombinant viral vector vaccine, where you take the help of another virus, which is supposed to be harmless to the human body, and use that to trick the immune system by, it's sort of like riding on a horse and going in like a Trojan. So that is another, that's the Oxford vaccine that's come out. So this is just a timeline to tell you that yes, we do have, it's easy to get impatient with what's coming out of science, but also recognizing that there's things are really going at full speed ahead. And even if we just look at treatment, like even from May, when I first started giving talks to our residents and sort of started looking at all this, between even May to now, like we have easy access to remdesivir. We actually can enroll people with convalescent to get convalescent plasma, and there's other stuff that are more easily accessible. We've gone from having difficulty in accessing tests in the hospital to now like universal testing. And I know that some of you are still struggling with testing in the community, but I think we've come a long way in that. And this just takes you towards multiple steps that you can see that are needed before we can say a vaccine is safe to be delivered. And during the time of emergency, there's that arrows there point to the combined phases, where people can actually come up creatively to combine phase 1 and 2, and then WAP, where the government can just name that these are the 5 vaccines that we really believe in, and just give them money up front on that. So the two vaccines that I feel are the ones to watch for would be, that I would bet on, would be one that is coming out of US Moderna and NIAID. This is an mRNA vaccine. And this actually, as pointed out here in my slide, on January 10th, the genome was sequenced, and within 45 days, actually, they had the vaccine ready based on prior experiences on other viruses that they were doing. So they were able to sort of make this vaccine in the mice model and then quickly just start the trial and started vaccinating on March 16th. So that's really a very short time. And this phase 1 study, which was dose escalation study, which is the first phase in which they give the vaccine in escalating doses to different age groups of patients, and again, all adults here, but still they've given to 45 healthy adults between 18 and 35 were enrolled, and 15 each in each group, given these incremental doses. And all developed immune robust response, and then some of them got boosters and they also had a good response. So the adverse effects that they saw were with the highest dose group and after the second vaccine. So this is very encouraging. They also looked at immunogenicity, they looked at safety, but they also looked at immunogenicity, and they looked at serum neutralizing activity, and they found that after the second vaccination, that the values were similar to those in the upper half of the distribution of a panel of controlled convalescent serum specimen, meaning that if somebody in the community has had COVID and has given their serum to donate to the convalescent serum because they have high antibodies, that's the level that this vaccinated patient or a vaccinated subject in this study after the second vaccine had. So that's pretty reassuring. The second one is this one that came out yesterday. The study was published in Lancet, and this is a viral vector vaccine. This is really, I recommend you to read about this study, and Dr. Gilbert, who is working in a Jenner lab at University of Oxford, had been working on Ebola and SARS vaccine for years. And when WHO sent out this call for vaccines, her lab actually just kind of acted on it really quickly, and they actually were really quick, and they went and did this phase 1 and 2 single-blinded study, which they've actually, RCT, which they have completed. And what they showed that they had acceptable safety profile, and they had homologous boosting increased antibody responses. So basically both humoral and cellular, both immunity for them. So they have started, or they actually already have a phase 3 program ongoing. So that is the other vaccine to watch. The virus that she used as a vector was the chimp adenovirus. So it causes common cold in chimpanzees. So I think with that, I just want to summarize and say that a few take-home points. I think what we saw together, and which some of you already knew, is that obviously the pandemic is very much ongoing. Hopefully seeing the numbers and seeing the perspectives globally gave some insight, and seeing that what's actually happening at LeBonheur in our community gave a little bit more insight. We are still learning, but, and I know it's very easy to get frustrated, and I've been super frustrated, but I think what's important is also to remember that we know way more today about this virus than we did a few months ago. I know that as an ID doctor, I have a lot more confidence talking to the families, and I have a lot more confidence telling Dr. Shah what I think we could be doing, how I can arrange medications if we need something. If you call me from the community, I have a better understanding based on the literature I have today about what to tell you than I had about 3 months ago. We have promising therapies. I think the other good point is that vast majority of the kids do well with COVID. MIS-C is real, and it can be serious, but it's also rare, and and it's also, most kids do well with MIS-C. In our hospital and across the country, most kids have recovered. There have been a few deaths, but for the most part, they have recovered. There are also promising vaccine results, so hope is on the horizon, and I think collaboration, research, and adaptability is key to overcoming this pandemic. I think these are my references, and with that, I'm going to see if you all have any more questions for me.
Yeah, Bindiya, this is Andrew. I've got a question, and I got dropped twice, so you might have already addressed this. Tell me what you think about the MMR and the protective features of MMR potentially.
MMR in the context of MMR
Well,
for COVID?
right, yeah. I read something, I cannot remember where, a couple of sources that had said that potentially administering a third dose of MMR can protect or help protect against the respiratory problems in particular.
So I don't know that I kind of buy into that, to be honest. I think it's speaking as a virologist, which I was in my first life as an ID attending. It's a paramyxovirus, so it's a little bit different from coronavirus. So I think we are jumping genuses there. So I would be very skeptical of that. I think some people have talked about BCG, which is also, I don't know if any of you have read that, that just in boosting the T cell response from that end, but not in terms of and that also hasn't really panned out. So as of this moment, I really don't know that I know the data to support that as an extra dose of MMR would help. But if anybody knows, please chime in and correct me.
Bindiya, this is Samir. I think the one important takeaway out here is the possibility of, influenza infections and
Yes.
how much havoc that can actually, create. And moving forwards, I think it becomes even more important that all our patients get immunized for the flu.
Absolutely. No, I agree with you, Samir. And maybe even wearing masks, the influenza season may look different also. I think there's just a lot of unknowns, right? It could be a lot worse. It could also not be. I don't know. But I think immunizations are the key, obviously, to prevent that. So, other questions?
Thank you for the great talk. Thank you.
Thank you. We good?
Yeah, I've got one actually. It's one that I've been asked. It's not necessarily a medical question, but I'm going to ask it anyway. A lot of people are asking me with the news of the vaccine, how we think, or if there's any history to tell us how we prioritize who gets it first.
That's a great question. And I think there's many articles to that addressing ethics of vaccination, right? I don't know, Clint, that's a great question. I think it might depend on the studies that come out that tell us who tolerated the best. The studies that they have, like the phase 2s, were all done on healthy adults between 18 to 55. Whether they necessarily need it or, they do, but do the people in the nursing home need it more, right? I guess that's the question, right? So I don't know. I'm hoping that if they do give it to those who are more vulnerable, then they actually have safety studies before they give it. I know that I would be giving it to my mom if there is at least one safety or efficacy study that says that it's not, super harmful in that patient population versus just avoiding. So I don't know. I think the right answer to that, I think we would want it to be prioritized to those that are the most vulnerable, but not at the cost of not having any efficacy and safety data on them.
Right. Well, one of the people that asked me was an elected official, and I said, well, I hope it's not you that's deciding what order we give a vaccine in.
There you go. Yeah. I bet the healthcare providers probably will, we may end up having to get vaccinated, because depending on exposure, right? So I don't know how they will mandate it. They may just mandate, all the healthcare providers also. When I say mandate, it may be just if I'm at UT, I need to have a flu vaccine to work. That's the mandate, not being politically, nothing's mandated from the top. I didn't say that. What else?
Dr. Bagga, I had a question about return to school. I know you mentioned in the beginning that you may not answer those questions. I don't know if I should ask it yet, or is there a different forum for that?
You can ask me anything.
Okay, awesome.
But we can discuss it.
Awesome. Okay.
Yeah, I can pass it on to somebody
Awesome.
who's working on it. But yeah, so Dr. Arnold and Highsmith and Jason is on. I don't know if he's still on the call. Jason, are you there still?
I'm here, and I think Cynthia's
Maybe-
still on. I think Cynthia's
ask the
still on as
question.
well.
Awesome, awesome. So the question I had is, some of our patients will ask, oh, what do you think are the risks of sending my child back to school? Or even like just a general question, other friends, colleagues, even us have this question in mind. So I was just wondering if there is any sort of a scorecard or anything that sort of has a bunch of questions that assesses the risk level of each household and the child and the people along with the child lives. For example, is there something like chronic illnesses in the child, any presence of proximity with older people at home? What are the local community rates? Is the local community compliant with wearing masks and social distancing? And what is the local curve? And is it better that younger kids who potentially are not going to be compliant with masks and social distancing do virtual learning from home, as opposed to older kids who will potentially follow instructions? And overall assessing the mental health of the child if they're just otherwise happy even at home. So is there like a scorecard or something that we can counsel for not just families, but also for colleagues and friends and ourselves, and just sort of like come to a more sane conclusion of what should we do?
I can.
Yeah.
Are you going for it, Jason, or I'm
Oh, sure.
going?
I can start, and you and Cynthia can fill in. I mean, no, there's nothing like that exists, unfortunately. I think that's a great idea. We should create an app that asks all those questions, and you can answer them all, and then get a green light or a red light as to whether or not you should go. But yeah, I think you have to answer all those questions individually for the family situation and for the child. You know, I think the way I've been counseling parents is, you know, as of today, that we should try to have children in school if possible. But the ones with, for instance, sickle cell disease, severe asthma, you know, other chronic conditions, especially kids on, you know, immunosuppressants or with weakened immune systems for whatever, that those kids may stay home. As Bindiya mentioned earlier, I think I'm very encouraged by the study out of South Korea that, you know, showed especially the younger children, 0 to 10, are really not transmitting and are not really a source of infection. So I think for the younger kids, I feel actually more comfortable with them, I think, even though they may not be as compliant with the social distancing and the masking. But as you said, you have to take into account, you know, who else is in the home, what is the social emotional state of the child. So yeah, it's a lot to account for and a lot to take in to decide. And I think, you know, I just feel like our role is helping families kind of walk through that, and then supporting them with whatever decision they feel like they make and what works best for their family.
Awesome. Thank you so much. I appreciate your help.
I think there's a lot more to come on the school, right, Jason?
Yeah, I know obviously the schools have all released sort of some plans, but I would expect some more guidance and, you know, as you said, the local situation may dictate a lot of that depending on what happens over the next few weeks.
Yeah. I think hopefully, like, if they're just looking at the data, you can see that the kids they do okay for the most part. So, you know, I think for me, like, that's the most reassuring part, that the ones who are older, the disease gets more severe in between like after 17. So the older kids are the ones that were transmitting it a little bit more also, and also getting more sick with it. And the younger kids, unless they're infants, then who cannot handle the virus, any virus well, they come in. But for the most part, they are actually doing okay. So
Great.
Yeah,
Thank you so much.
I think the tough thing is that we're up against
hi,
myths.
Cynthia.
Hey, how are you? Can you hear me?
Good.
Okay, so I think one thing we're up against are the myths and the misinformation that's circulating in the community. So even though we have, I think, pretty good data, it's not always embraced by the folks who really need to hear it. And I think we're seeing some of that. We still have, I think, a good bit of information to process through and get to the schools. The other problem is that there are multiple school systems, school districts, if you will. And some folks want to do things a little bit differently. And then some have better resources than others. And that's a problem too. And then that has to be balanced against the fact that many kids from underserved areas really need to get back to school. But those are the same kids who come from multi-generational homes that may have adult caregivers with chronic illnesses. Yeah.
It's hard. I was telling Samir today that my son has to go to college, and I mean, has to, but I don't think he will. He'll probably do virtual learning. We are still waiting to hear from WashU also. So, but most of his friends, even Rhodes has closed campus. They are not going to have any kids on campus in fall. So it's not an easy decision, but I guess I think our job as providers is to just give confidence, and like Jason also mentioned that help guide the family through this, right, and be involved in task forces, kind of like how Cynthia and Jason and others have been working to lead them through that. So hopefully more to come on that. Other questions? Sorry it went over, but you can't not know vaccines when you call ID. Are we good if there's no more questions? No one's saying anything.
Thanks for me. That was great.
All right, thank you. Thanks for listening in, everybody.
Thank you very much, Bindiya.
Thank you, Bindiya.
Thank
Bye,
you so
guys.
much.
Always love having you.
So take care, be good, call us if you need us, okay? We're there for you.
Great.
Thank you,
Thank you
Bindiya.
so much.
Thank you. Bye.
Bye.
We recorded, guys. We'll send that out for you.
Great, thank you.
Great. Thank you.